All right, so update again on the AM-PAC. So if you want to go to the next slide. Starting first with just reviewing the history. So what brought about the change? The current screening tool provided very limited useful information. So again, we had the idea to use the 6 questions from the AM-PAC, put that in place of those questions that you find in the adult patient profile. And so now we've got an evidence-based approach to do some patient mobility screening. It's allowed us, which we'll share in just a minute, some more meaningful data collection. It definitely supports our needs as far as evaluations of patients, but then we're also looking at trying to use it for discharge preparation and planning, a little bit better efficiency with that. So also to try and help physicians and then case management. So again, these are the 6 questions. Scoring goes from a 1 to a 4, with again 1 being unable, 1 being unable, and then 4, no difficulty with the task. So again, the highest score you can get is 24 points, just meaning no disability or completely independent. So what we flagged, again, just as a reminder, the reason why it's bolded is because what we've proposed is to generate a PT or OT consult basically above 10 and below 21, because obviously within that range we're looking at that the patient would need some kind of rehab services following their inpatient admission. So the data collection was over 10 weeks, so from October 21st to 2018 to January 4th, 2019. So we had 6,395 patients with the AM-PAC completed. So out of that, we had 46%, or 2,928, that received a PT and or OT evaluation. Again, we'll highlight this because it'll be more meaningful here in just a minute, but this was based on the physicians placing the PT and OT consults, just like we have for a while.
Could you clarify what patient group and where this was? Just.
Oh yeah, so this is just on all medicine teams, both at Good Sam and Chandler. So none of the specialty services, just the medicine team, which I think now is up to like 21 or 22 teams. So again, looking at the accuracy, so again, to kind of highlight this was just driven by nurses providing the assessment. So basically, once the patient's admitted, they have within 24 hours to complete the adult patient profile. That's where the questions were, so it was just the nurses that were performing the AM-PAC 6 clicks. So this was the accuracy. So what we were able to do was track at the time that the patient was admitted what their score was, and then track at the time of discharge where they were discharged to. So that allowed us to see where we are as far as accuracy on when the patient comes in and when they're discharged. Are they discharged to the appropriate setting based on the score from the AM-PAC? So you see it based on the different score ranges. So again, 6 to 10 would mean you're needing some type of long-term care, whether it's in a hospice setting, a facility, wherever. 11 to 15 would again mean that you need inpatient rehab, whether it's acute or subacute. 16 to 20 would be the home health or outpatient services. And then 21 to 24 just means that you're good enough to go home without needing any services. So obviously our accuracy was best within the 21 to 24 range. Not so good really in all the other ranges, but again, as it applies to us, we really want to try to improve the 11 to 20 range, because that means that the patient needs our services. To give you context on prior places that the AM-PAC was performed, the Cleveland Clinic, they did a research study involving 200,000 patients, and the AM-PAC was, in their reports, 84% accurate as far as when it predicted the discharge setting that it was correct 84% of the time. The caveat to that was when PTs and OTs were performing the assessment at the time that the patient received, or at the time that they received a consult for PT or OT services. So with that being highlighted as far as needing improvement, what we've proposed is to try and do a validation study, because again, we're doing something different than what research has already proven to be accurate. So again, we're trying to do it earlier and also trying to use the nurse to help us screen for the appropriate time that we see the patient. So again, we're including all medicine teams at Chandler and at Good Sam for a 6-week period. What will start in February, actually it'll start tomorrow, is that the AM-PAC will be in our notes. So under where you would typically find like the Kansas, the Barthel, all those assessments, the AM-PAC will be built into that, and that will be available starting tomorrow. The part that we don't know is the next part, because we're still trying to go through administration to get everybody to give us approval. But they will, and by they, it's IT, but IT will activate the auto-generated PT and OT consults for any patient that scores between an 11 and a 20. So what we're proposing to do for this validation study is compare the accuracy of the AM-PAC score between the RN and then when PT and OT performs the assessment when you receive that consult. So theoretically, just like we do, it should be within that 24-hour window that we receive the consult. So to put everybody at ease, during the past 10 weeks, what we did to anticipate a volume of that auto-generated part is I went through all those 6,395 consults, and out of all those, we missed 901. So that would result over that 10-week period in just 13 additional consults per day throughout all medicine teams. So that's less than one.
Are you saying that the MDs didn't consult us on 901, or we didn't see 901 patients?
We didn't do consults. So,
but what if I'm the lucky one that gets 5 of those 13 that day, Robbie?
You're lucky. You buy a lottery ticket that day. So like I said, between all the medicine teams, that's less than one consult, per medicine team. So again, I realize that that's just an average. It could vary to where, just like you said, one day you get hit with a bunch and then you might go 2 or 3 days, and not get any. So that was a way to kind of, for us, to look at the volume to say whether or not this validation study could be done.
What's going to be really interesting is we can then drill down and see if there's certain, whether it's groups of doctors down to the actual physician, and see who is not putting these in a timely manner. Does it happen more at Chandler? Does it happen more at Good Sam? Does it happen more with weekend admissions? So it is, in the end run, going to give us a lot of good data.
So do they redo these AM-PAC scores like periodically? So like if we get somebody that's actively detoxing and their score is going to be 4 or whatever, they're not appropriate per se for us then, but in a week when they're kind of coming out of it, then are they going to continuously do this, or is this just upon admission and that's it?
Just upon admission.
Okay.
This is the only time they do it.
But they can still put in consults if they think they're appropriate. That's the normal 6-foot thing, right?
Yeah. So that'll still be, like I say, right now nothing has changed except for them. If the patient scores within 11 and a 20, within that range where we're saying that they would need PT or OT services, it will auto-generate a PT and OT consult based on the physician for that team. So it's even going to be that particular, that it'll still be that physician's name that's on service for that team.
That's good for business, guys.
Yeah. Obviously, it still comes to us as far as, once you read that chart, screening, just like you said, for whether it's detox or whatever, medical appropriateness. But if the nurse, and that's why we're doing this, to say if the nurse is accurately assessing this patient and they score between 11 and a 20, you shouldn't have as many of those questions as far as medical appropriateness, because they should be able to do something. Yeah.
Have all the nurses throughout Chandler been doing this, that, like maybe on the 8th floor, it just wasn't part of the study?
Yeah, so enterprise-wide, this has been integrated into the adult patient profile.
Right.
So all nurses everywhere have been doing this since October, whatever that was.
So we've
26.
run into a problem where our case managers are getting discharge recs when this, I assume when this is done, before we've even seen the patient. And so then when we come and say to the patient, disagree with the recs, it's throwing everybody off, and they're getting upset that we suddenly changed the recs that we never put forth to begin with, because it was the nurse making the call before we even saw the patient.
Or we're not getting consulted to the last second because
Right.
they see the recs where PC and OT recs are, and 6 split said rehab, but
Right.
then they never consult us because what case management sees is they rehab recs.
Yeah, so it's kind of been a problem in that regard for us, because they're getting false recommendations that aren't accurate.
So I've communicated, well, I've been in constant communication with their supervisors as far as case management goes. I will follow up with them about that, because that's not something that's ever been pushed forward.
No.
That's just something maybe that those particular case managers on that team have, for whatever reason, kind of done on their own.
Well, I
So-
think they could be confused because right now this paper is going right off the bat to your physicians. It's like we're giving them the authority to take a discharge direct, so they're gonna always go by what the physician says, and the physician's gonna put it in.
No, right now this is just a screening tool, and that's
Yeah, it's just
been,
a number, so someone's
Number.
going to the next step without being instructed to go the next step.
It's
That has
going-
never been.
It's going to the next step.
Well, it's going on the rounding report. When we go to, yeah,
Right,
it's
so
going.
where else, this is the first time I've heard of this.
Yeah.
So where else is this happening other than AIDS?
Ours shows up on the report one too. Yeah.
And that gets auto-populated to all the cases.
It does, it gets auto-populated.
so what floor is 8th floor and which one?
Is it say a recommendation or a number?
Yeah, I don't, this is the first time we're hearing about this, I'm not sure how it's.
Ours shows up as a number and like a wording recommendation. It's a wording, acute rehab or home.
Interesting.
Yeah.
Yeah, I'll follow up with
We
that,
will follow
because that's
up.
never
The intent was just a
Man.
number, so it's
Right.
meaningless.
proved or anything. So again, like I said earlier, it'll be included in SCM under all the standardized assessment tabs. The big thing in this slide is really for all of us to be on the same page, because when we do a validation study, we want to make sure that everybody is doing it the same. So just like we've talked to the nursing staff, but we want to do the score based on the patient demonstration of the skill. The caveat is that clinical judgment may be necessary for some questions. So like the 6th question, ask the patient how much difficulty you have performing stairs. So an example would be, obviously if they're struggling to walk 10 feet in the room and you grade that as a 2, then for stairs you could either grade that as a 2 or a 1, saying that they still have a lot of difficulty with that without having them actually performing the stairs. Because again, it's not appropriate for that patient at the time. Same thing with like the bed mobility questions and things like that. So if you're getting that stopping point, you know, with your assessment, and you know, you don't feel it's appropriate that they walk or that they do stairs, then you're grading them based on what they've been able to demonstrate to you up until that point. Yeah.
What if they don't do those things at baseline?
Yeah, so again, you would just put that as unable, because if they're not doing it at baseline, they're not doing it.
Okay, so we're not differentiating, you know, what a baseline score would be versus their inpatient score?
No.
Okay.
Because the purpose of the AM-PAC is to grade them at that time and place, you're not really basing it on prior level of function or anything like that, because again, the purpose of it is to try and make recommendations for discharge upon leaving the hospital. So obviously we know that people have, you know, injuries or illnesses that's going to debilitate them throughout the rest of their life. So you're looking at what it is for time and place right now. So again, the scoring rubric for us, with the bolded part being how it shows up on the AM-PAC as far as being unable to do the activity. For us, if we say that they're dependent, that's going to be unable. If they need a lot of help or assistance, that would be when we grade a max or a mod assist. If they only need a little bit of assistance, that would be min assist or contact guard. And if they don't need any assistance, then that would just be standby or modified independent. But that portion is really important for us kind of going forward, that we're all on the same page, so that when we do grade these patients as far as this validation study, that we all use it, you know, accurately in the same terminology. Again, we'll, you know, send this out to everybody following the meeting just so you can refer back to it. I'll let you know once we have received approval from administration to do the auto-generated part, because in that point we'll have like a start date as far as when the 6 weeks validation study will begin, as far, you know, start and end date, so that everybody is aware.
So as far as rehab staff, like it's on initial evaluation only?
Right. Yeah.
And it's going to show up for everybody starting tomorrow.
Yeah.
But if
As a
the
test.
PT don't match, like rebalance separately.
That's still okay.
Okay.
Yeah, that's okay.
So we've been talking about the AM-PAC for a long time. We've purchased the rights to use it. So even if it's not part of your group of medicine patients, it's open and available for use. I just got a screenshot sent to me that's quite interesting that I'll share with the rest of the group, that I can see why it leads to lots and lots of confusion on that rounding report. Dr. McDowell is super pumped about this, and what I think Robbie has done all of this, honestly. Robbie gets a lot of credit for this. What's really exciting is, and correct me if I'm wrong, I don't think there's really been a study that looked at the difference between when therapy did it versus another discipline, such as...
No, and that's the thing. So we're trying to do it to help our own throughput, because like we've all kind of explained and been disgruntled with, is that we don't get to the right patient at the appropriate time. So what we're trying to do is, especially with this auto-generated part, I mean, again, essentially you'll get there, you know, within 24 to 36 hours of the patient being admitted to the hospital, rather than you receive that consult and it's got their date of admit as 6 days prior, and you go in there and think, well, why wasn't I here 5 days earlier? Why am I here just now? Because, you know, the patient's been deconditioned and a whole host of other reasons. So it's really, for that purpose, we're trying to use this as a way to where we identify the patients that will need our services, and that we can get there, you know, sooner rather than later. And it, you know, obviously, depending on the physicians, to put in those consults has been very sparse as far as the efficiency and just being able to repeat it more specifically on the medicine service lines than what it pertains to the different specialty service lines, because everybody has their own kind of like protocol and things like that that work for those specialty services. So it's really to try and help out the medicine teams, the ones that we all know. You know, you'll have different residents on there, the physicians rotate every week, so there's a lot of turnover with very little consistency.
Katie's up next.